Hi, my name is Brittany Davis. I'm a general surgery resident here at Stanford Hospital. I would like to thank the college for allowing me to present today on the surgical treatment of the neurogenic etiology of median arcuate ligament syndrome. Median arcuate ligament syndrome, or MALS as we commonly refer to it, is thought to be from the compression of the celiac artery by a low-lying median arcuate ligament. The patients that present to us with this typically have a long-standing history of epigastric pain that's usually worse postprandially. They also report nausea, vomiting, weight loss. Some have been on chronic pain meds with a multimodal regimen for years with no relief. The etiology is thought to be ischemia, but there's a lot of controversy surrounding this. The controversy is based on the fact that we have quite robust collateralization of mesenteric arteries. As you can see, even with the celiac artery being knocked off in our diagram on the left, you still have feeders from your SMA and your IMA into the mesenteric collaterals. And we see this all the time clinically in patients that have atherosclerotic disease. Even if they have completely occluded celiac, or in addition to that, maybe also included SMA, as long as they have an IMA, one vessel that's still patent, they do not present with any kind of mesenteric ischemia. You need all three to be involved. As long as you have one single mesenteric artery, you have adequate mesenteric perfusion. So there's also a high frequency of recurrence in patients that undergo the current standard of care treatment for median arcuate ligament syndrome, which is a median arcuate ligament release. Typically in the surgery, which is usually performed laparoscopic, can also be performed open, the median arcuate ligament is resected. Now, anywhere from 30% to 80% of these patients, depending on the report you read, return with recurrent epigastric pain and the same constellation of symptoms that they had sought treatment for in the first place. So with these two pieces of information, it raises the question is there a neurogenic cause of median arcuate ligament syndrome? And our argument is yes, there is. You have the celiac ganglion plexus that sits right on the celiac artery. As you can see in our diagram on the right, we have both the right and left plexus, and it's very intimately involved with the celiac artery. Now, if you have compression and a constant irritation of that area, the nerves can become irritated themselves and cause a neurogenic etiology of epigastric pain. Now, in our study, the diagnosis of MALS needed to include a clinical exam that showed tenderness to the epigastrum, some form of imaging that showed a low-lying median arcuate ligament with compression of the celiac artery, and they needed to have relief of pain from the celiac nerve block. There were 102 patients that we looked at in this subset of our data who underwent our median arcuate ligament release with extensive celiac ganglion resection, which is the addition from the golden standard of today. We also resected the entire ganglion around the celiac. We then performed a retrospective review of long-term post-operative symptom improvement, and we evaluated the recurrence via electronic survey. Specifically, we looked at patient demographics, their presenting symptoms, their post-op symptom resolution, recurrence rate. We analyzed this with the t-test or chi-squared, depending on the data. In this presentation, I'll be talking exclusively about our symptom resolution, so the data is analyzed just with the t-test. Post-operatively, we saw roughly 49% of patients have pain entirely resolved. Just a little over 40 had their pain improved, while about 6% showed no difference, and 5% actually had worsening pain. When we look at their overall subjective pain scores, preoperatively the average score was around 8.4. Post-operatively, the pain score was around 6.8, 6.9. These patients had a significant improvement in their pain. It's reported to be less than 0.0001%. Sorry, p less than 0.001. So very statistically significant change in their subjective pain scores. We did also analyze their return to their activities, return to work. That's not presented here, but the patients did have a report of better quality of life following this procedure. So we had roughly 89% of our patients undergoing the median arcuate ligament resection reported either complete resolution of their symptoms or improvement in their symptoms after the median arcuate ligament resection in addition to the celiac ganglion resection. This is a superior response to the 20 to 70% that report improvement or resolution in their symptoms in the existing literature. But, however, this has been a study looking at the outcomes 3 to 6 months post-operatively. We need longer-term follow-up to assess if this response is going to be sustained, or if the recurrence rates become higher further out from surgery as we go. So we argue that our clinical and anatomical evidence suggests possible neurogenic etiology to malls, particularly as resection of the ligament alone leads to a higher rate of recurrence compared to a resection with a ganglion resection as well. Mall surgery that targets the celiac ganglion seems to have a higher rate of postoperative success. And if our post-op results are sustained long-term, this will help support this neurogenic etiology of the disease. Thank you so much for your time today. I appreciate you listening in, and I hope you stay healthy and have a good day. Thank you.